So a lot of patients ask me how uh, long do stents last. So I think the stent can last for any duration of time. So for example, this was a patient on whom I put up a stent across here for a primary PTC about 2-3 years back, and the patient had left in 2022 basically. I don't exactly remember the month, but anyways, after 3 months, the patient was lost to follow up and presented again after such a long time with complaint of chest pain. Uh, the stent in the LED was functioning still, but as you can see, this was a RCA 100% stent, and you can see that it is a very blunt tip. The chest pain was of about 6 to 8 months duration, and the LCX injection also shows that there's a tight lesion in the L6, also in the ostial, and the patient had already developed collaterals towards the RCA, and you can see grade 2, grade 3 collaterals. So this was a CTO, and interestingly enough, the patient had already been when the patient had chest pain about 6 to 8 months back, the patient had already been tried opening of this lesion because in a different city, and maybe I don't know they were I don't think they were successful because the patient presented to us again for the same thing. Anyways, to cut this story long short, this was the lesion that we got. We used the JR 3.5. We could easily have used the AL 0.75 or the AL1. We were more comfortable with the JR in this case. Anyways, so we had a difficult time crossing the lesion. Now please understand that I prefer workhorse wires before escalating. So my preferred workhorse wire is a BMW, and even in this CTO case I would prefer to go first with the workhorse wire, maybe give a balloon support, maybe and only if it does not cross, then I might go for an extra support wire or maybe a taper tip wire like the Fielder XTA, and maybe escalate to a Gaia 1, anyways, Confianza. But this is the BMW wire, and you can see that I had to take a balloon support right here, and it was a very difficult crossing. I did not make a lot of tip so that if I bend the tip a lot, then the penetration power obviously decreases, and thankfully enough I can see that the wire has crossed. It has gone into the side branch, and you can see that the artery has started to open up after some predilation, of course, not predilation but daughtering of the. Anyway, so I had used RO view to go, and slowly we have gone into the vessel, and anyways, we're doing some predilation here, some predilation here, good predilation basically, and you can see that the artery has started to open up. Some daughtering, after some daughtering and predilation, where again, and the artery has opened up quite nicely, and you can see that after some nicorandil, some thrombus aspiration via the catheter itself, you can see that the artery has opened up. You can see some organized thrombus here. Yeah, this organized thrombus is very notorious, but anyways, so we're going to go. So this was a 3.5 by 36 mm stent, and We've placed the stent via the when we injected it. So basically, when we were putting the stent across, and this is a very good technique, I call it the waterfall technique. This is my waterfall technique. I do not know if anyone else is using it or not. So basically, when the stent goes in the artery and the artery gets blocked because of the diameter of the stent itself, so that you cannot see the distal where the distal edge of the stent is being kept. So you can just ask your assistant or the cardiologist standing next to you, the assistant, that just give the push in the die, and then you will introduce the stent with the die, and you can place it accordingly. So anyways, I know now that where the distal end of the stent is, and we have inflated the stent right here. A very tight lesion, 3.5 by 36 mm stent, and yes, the artery has opened up quite nicely, but I can see that there is a 70% lesion just below. So let me just show you. Well, this was the 70% lesion anyways. So even though the generally distal stent is placed first and then the proximal stent, but anyways in this case we had to put an proximal stent first, and anyways we post dilated the junction at 14 atm pressure with the stent balloon itself, and also post dilated the proximal stent also with the stent balloon. Anyways, we're using a high pressure NC balloon and for post dilatation, and you can see that we're post dilating it quite nicely, post dilating it, post dilating it, post dilating it. This is the proximal stent. Anyways, post dilatation, this is the distal stent opening up quite nicely, junction, post dilated the junction anyways, and I think the artery has opened up very nicely. You can see this is a 3.5 artery, and this was the first artery. This was the lesion first, and after opening up, this is the artery. And the wonderful thing is that, and to what the information is that, or what the learning is that one can even use a workhorse wire, and there's a certain series of escalation that you can do. I could have easily used extra support wire to just go ahead and or just cross the antegrade crossing of the CTO lesion, but that had a risk of intimal dissections or intimal penetration, and that really could be problematic. One certainly has to use it sometimes, but the levels of escalation should be very important, and one should know where to use which wire, and very important. Anyways, so this was the CTA lesion, and you can easily see the collateral supply that is going towards the RCA. I think you will be seeing it in a moment. Yeah, you can see this, the RCA is being well supplied by the LED collaterals. Huge. And anyways, RC collateral. So typical RCA CTO that we've opened up quite nicely at Agra Heart Center, and this is the final view. This was the first view, and anyways, the patient did well. He's been discharged after 48 hours. Thank you.